into the room.
This meeting is being recorded.
And sounds like we're recording in progress. So let's go ahead and kick it off. Welcome, everyone. Hello, and thank you for joining us today. Welcome to our second SAB Talks. Today's session is on GLP-1s. My name is Emily Stone. I am on the Science, Marketing, and Communications team here at Ideal Protein. I am joined by Dr. Rothrock, our Chief Medical Advisor and leader of our Scientific Advisory Board. Hi, Dr. Rothrock.
Hi, how are you today, and everybody?
Good. Thank you so much for joining us. Just going to start with a little bit of housekeeping before we get started. If you could advance next slide, Julie. Thank you. So this meeting, we are recording the meeting. We will be sharing it afterwards via our newsletter. We will also post it to the Ideal Protein Academy. Just remember that the topics that we present today are informative only. They are not intended as medical advice. Keep in mind that when you're serving your patients and clients, you should always defer to that individual's prescribing practitioner. We won't be talking about any case examples today, but just keep in mind that anything we share is really just for information purposes only. If everyone could please keep your mics muted, that would be helpful. Any questions you have, if you want to drop them in the chat when you think of them, that would be great. We will keep an eye on the chat, and we definitely will do some save some time at the end for the questions. So all right, so let's go ahead and get started then. And before we dive in, I want to start with a couple of polls so we can see where the room is at really. So I'm going to launch a couple of polls, and these are just a couple questions to answer where you are right now. And the first question is, how confident do you feel currently supporting clients who are using GLP-1s? And you can answer very confident, somewhat confident, not very confident, or I feel pretty confused, which is totally okay. And then the second question is, when it comes to GLP-1s, where do you feel most unsure right now? So I see people are bringing in some answers. This is very interesting. So is it what GLP-1s do in the body? Is it how different GLP-1 medications differ? What people are typically going through when they're on a GLP-1? How GLP-1s affect phase 1? Generally overwhelmed by all of it, or something else? And if there is something else, feel free to put that in the chat. We'd love to hear also what might be on your minds. So this is really great. I see answers filtering in. I'll give it just a few more seconds. So if you are still waffling, go ahead and submit your answers, and we'll go from there. All right, guys. Thanks. That's really, really interesting. I'm going to share the results. So it looks like we really stand somewhere in the middle, confidence-wise. We've got some that are on either end, but a good bell curve in terms of confidence, with most people being somewhat confident working with the GLP-1 patients. It looks like for areas of interest, a lot of interest in the different medications. Okay, that's great to know. And then, but a smattering all over. So. And if you are very overwhelmed by all of it or any of it, that's okay. When Dr. Rothrock and I were prepping for this talk, and I was asking him some questions, and he would stop and say, that's a good question that the medical community is asking too. So, you're definitely in good company. So there's definitely a lot of information out there. It can leave us feeling a little bit confused or unsure. And we can feel more confident talking with clients just the more we learn, even if we are ever going to know every detail. Our goal here today, and you can go on to the next slide, is really to bring out some clarity and some confidence, and it's not necessarily to bring a lot of clinical depth. This is GLP 101. So we're going to focus on some fundamentals and really grounding what the medications are, how they work, what the differences are between the different options on the market, and what our clients are going through as they are on these medications. So we'll keep this session practical and high level. Dr. Rothrock will be able to share his firsthand experience as a clinician and somebody who is actively using these medications in his medical practice. So, and then my role will be to focus on what's most helpful in our coaching conversations. All right, so let's go ahead and get started. So I thought it would be interesting to just kind of start off with this slide, putting us into perspective of where we are today. And we know that these GLP-1 medications are showing up more and more in our clinics these past few years. And this slide, I think, really emphasizes why. It's comparing weight loss over an 18-month period with diet and lifestyle alone. That's your yellow line at the top, and it's showing about a 6% reduction that we can expect from diet and lifestyle. And then you compare that to our two blockbuster GLP-1 medications, the green and the blue line, and we see 15 to 20% weight loss with these medications on average. So it is clear that they are game changers. Compared to diet and lifestyle, people are getting the message that maybe all I have to do is take a medication. So we're going to dive into this. So let's start by just breaking down the effect of like, why is it that these medications are able to get so much more weight loss than diet or exercise alone? And
Emily,
so I want to.
could I point something out about that slide as well while we're chatting about it? You look at the timeline on this slide here. It's 18 months. Most of the prominent studies done on the GLP-1s are 72 months long. So the weight loss, as you can see, looking at these things, is pretty gradual and it's pretty continuous. A lot of people think this is a very short order thing. It's not a short order thing. It takes, again, the studies that showed for tirzepatide, a 26% weight loss was 72 months. So a long time.
Okay. All right. Yeah. So for those of us without a medical background, I'd love to hear how you explain what GLP-1s are and what they do in the body. So let's really dive into these effects. Where are these effects coming from?
Well, I think one of the important parts about understanding GLP-1s is that it's a natural substance. Our body produces these substances, so this is not a foreign substance in the sense that it is, a drug or whatever. It is augmenting our body's own system of GLP-1, and one of the most fascinating things, and a lot of people involved in our level of healthcare, I've heard a lot about peptides. Various peptides that do various things. Well, GLP-1 receptor agonists are peptides that, in fact, work in the GLP-1 mechanism. So it is a peptide. It's a peptide hormone, and it works on the GLP-1 and GIP receptors.
And we have a slide about that. If you want to go forward there, Julie. Thank you.
So where are the GLP-1s made? Well, actually, it's an absolutely fascinating system, and a lot of people don't talk about where the GLP-1s are really coming from. They're produced in three different areas. They're produced in the pancreas in alpha cells. They're produced in the L cells of the intestine of the small bowel, and they're also produced in the brain. There is in the posterior medial hypothalamus. There's production of GLP-1s, and that kind of goes and shows you the three basic different areas that the GLP-1s actually work. The beauty of the GLP-1s again is that they are a natural substance, and they are part of what's called the pro-glucagon molecule. A lot of people have heard us talk about glucagon insulin and how important that is in ideal protein and the whatnot, and it is very important. One of the most actually really elegant control mechanisms for this in terms of GLP-1s is if you look at the way they're made in the L cell in the intestine, pro-glucagon is actually the molecule that's produced genetically. And post-translationally, the pro-glucagon molecule is broken up into different peptides. One of them is the GIP, another one's GLP-1. There's also a GLP-2, by the way, and also glucagon itself. So, and the what actually happens post-translationally depends on the insulin receptor on the glucose level. That's why it's such an elegant control mechanism, because what you're really, if you step back from this a little bit, what you're really trying to understand is what these things are doing naturally. What they're doing naturally is helping us control our appetite. And as we eat, we want the system to slow down. And that's exactly what happens. So what happens is that if your blood sugar goes up and your insulin level goes up, the GLP-1s are secreted. If you're starving and your blood sugar goes down and it's been a while since you had a meal, you kind of want to rev the system up. And what happens is instead of the L cells producing GLP-1, they produce glucagon. So glucagon, as we know from our ideal protein work, it stimulates us to eat and stimulates the insulin glucose system to uh, increase glucose in the body. And so it's a really elegant system. And by the way, why we've talked before on some of these GLP-1 talks, this explains why if you get hypoglycemic, that the GLP-1 system shuts off. And it starts producing glucagon to cause the opposite effect. So it's built-in control system, and why we can do phase 1 with people on GLP-1s, because there's the natural control system that comes into play. So people do not get hypoglycemic. So you've heard us talk about it's a glucose dependent area of control, and that's how it works in the post-translational area.
Okay, so we are really working with a natural mechanism of the body here.
Right, and it's a natural control mechanism that we're just augmenting, actually.
And how is that happening? How is it that these medications what are they doing that's different?
Well, what they're doing generally 3 different things. First of all, increasing insulin secretion, the GLP-1s, that's one of the more basic things. That's why, remember that the GLP-1s were originally utilized for type 2 diabetes. So that's where it works on type 2 diabetes. And we'll show another slide coming up here, but as the development of the GLP-1s has come along, the weight loss element of it was demonstrated. Part of satiety, part of us understanding, our body's understanding that we've eaten enough, is that the GLP-1s begin to be secreted post-translationally. That slows down the emptying of our stomach. Mm-hmm. It slows down the movement of our bowel or peristalsis. It slows down bowel movement. All of those things tend to decrease appetite. Mm-hmm. It also, and this is maybe the most important part of it, is that it decreases our appetite in our brain and our hypothalamus, mm-hmm. Where our major mechanism for appetite occurs. So it decreases our appetite, it decreases our motility in our stomach, decreases emptying of the stomach, decreases bowel peristalsis, and those things cause satiety. All those things cause a feeling of I'm full, and people don't want to eat. The extreme of this, of course, those of you who have some experience with these drugs, the extreme of this is people don't want to eat at all. And that's where we kind of step in as Ideal Protein and make sure that we help the patients on GLP-1s eat the things that they have to eat, which is adequate protein. Kind of the classic Ideal Protein help, so that people don't get Ozempic faces, which became famous because I think the Hollywood people got a hold of this stuff and were using it without supervision and without any help, and they lost muscle mass, and they looked terrible. They looked like they were gaunt and starving, and of course we don't want that. So
yeah. All right, so here we're showing what that natural GLP-1 hormone does in the body. It hits these cells. It has those effects you were talking about of slowing down the GI system, of making us feel fuller. The medication versions are going to be kind of doing that all day long, right? Versus you were describing this normal release when we eat, but our medications are going to be kind of in there all the time.
Sure, they're gonna overrun the system, so to speak. So
Mhm.
we have that inhibition of our appetite and feeling of fullness all the time, as you point out.
Yeah. Okay. So then, so our next slide is going to show what we call a dual agonist, and we'll get into this a little bit later, the GLP-1 versus the GIP. But you were talking a little bit about this, about various hormones, and some of our GLP-1 medications, what we call GLP-1 medications, are not only activating GLP-1 shown in blue in this slide here, but also hitting on the GIP hormones as well.
That's right. The index medication, which is semaglutide, is basically a GLP-1 receptor agonist. It's a 31 amino acid peptide that activates the GLP-1 receptor. The second drug that became available is tirzepatide. Tirzepatide, and that's the trade name is Zepbound, and it's produced by several companies actually, but it's a GLP-1 agonist and a GIP agonist. GIP stands for a gastric intestinal protein, and so it has an additional effect on slowing peristalsis and gastric emptying.
And if we go back to that slide or if we think back to that slide with the graph and the two lines, that the lower the line with the more weight loss was the medications that use this dual
right,
mechanism.
the gastric inhibitory protein GIP. And just to confuse things, we don't have it on a slide, but right now in clinical trials is a medication called retatrutide, which is an oral triple action GLP-1. It does GLP-1, GIP, and also is a glucagon receptor antagonist. So it does all three things, and it appears to have more effective weight loss than tirzepatide. So as we add more receptor understanding, more receptor inhibition on the system, we create more weight loss. And those drugs it's in phase 3 clinical trials right now, and probably will be out in a year or so. So these drugs are being researched actively as we go along.
So we're really manipulating the body here by playing on things that the body already does.
Yeah.
But you know what I think is really what I always come back to when I'm thinking about how these medications work is that they're making us not hungry. They're turning down these signals for us and slowing down our system so we're not hungry. But they are not telling us what to eat. They're not replacing nutritional quality. So that's where you get the Ozempic face or the just the overdrive of it. And if people aren't properly getting that behavioral support from us, they can be missing quite a bit because the mechanism itself is not making you necessarily eat the right foods.
I think that's a great point, Emily, and it suppresses all appetite, there's nothing, it does not, the suppression does not look at the different macronutrients at all. It's just basically all food.
Across the board.
By the way, not just food, but water. I mean, people also get dehydrated as well. So it's pretty much almost a bulk way of looking at things, for sure.
And so the coaching implication there is that we really do need to keep an eye on what people are recording in their journal, not just the food intake, but also the fluid. Are they keeping up with their water? Because both of those can be depressed. And in some ways, it makes it easier to follow our protocol because maybe they're not feeling the food noise of foods that are not on the protocol, but at the same time, they may also be having difficulty eating enough of what's on the protocol. So it changes a little bit of how a little bit about the experience of the client coming in.
And as we've talked before, I think on this format, one of the things we think is incredible in terms of the synergism of ideal protein and the use of GLP-1s is GLP-1 is suppressing your appetite. So as you all know, does ketosis. And so when we add synergistically ketosis with a lower dose GLP-1, and this is what we've seen in some preliminary studies we've done in Ideal Protein, and what we've talked about is that we get the additive effects of the two um, appetite suppression in a very synergistic and excellent addition way. And of course, as Emily said, our ability to follow patients on this and supervise and coach is key because especially those of you who have body composition analyzers who want to make sure that people don't, in fact, start losing lean body mass and that they are eating adequate protein as a la phase one of the protocol.
All right, well, let's move on to our next section here. And this is just to review the weight loss mechanisms here, really suppressing that central appetite on the one hand, and also delaying the GI tract as kind of our mechanisms of how GLP-1 works. So in our next section, we're going to go over the different medications.
We could go back to that last slide for just a second, for just 1 second. It also, we didn't add this into the slide, but also it slows peristalsis of the bowel itself, including the colon. This basically is where the side effects come from too. So you can predict the side effects based on its effects. And, different than some medicines that we use, the side effects aren't really side effects, they're effects. And whether a person feels them a great deal or not a great deal is sort of an individual thing. And kind of why, as you probably guys all know, that we titrate these GLP-1s over a pretty long period of time, starting at pretty low dose and increasing them to what's thought to be the appropriate dose for weight loss or for diabetic control. But we see
those side effects, those are going to be constipation,
nausea, heartburn, all things that are related to slowing really of the gastric of the GI tract. And we've talked, I think, before about some of the coaching implications for, watching out for these different side effects and being able to help the client with them.
Okay, yeah. So let's move forward then.
I think one of the most important things, were you going to say something, Emily, first? Or did
No,
I
you go
jump?
ahead.
Well, I think one of the most important things about the GLP-1s is that they have such broad effects. So initially it was centered on type 2 diabetes and the pancreas, but subsequently it's been shown that GLP-1s generally are very anti-inflammatory. And that has implications on a whole lot of organs. In my business in cardiology, in the last year, they got put on 2 guidelines for both coronary artery disease and congestive heart failure. Significant improvement in angina, a significant improvement in risk of cardiac ischemia or heart attack. Actually, an improvement in congestive heart failure, rather substantial. So they're on those guidelines. The brain, as you see here, there's a lot of effects on the brain, and there may be some reduction in neuroinflammation, which may have implications for dementia and Alzheimer's disease and degenerative diseases. It looks like the liver, it may be one of the ways they're actually looking at one of the newer GLP-1s to look at it in a clinical trial to treat steatohepatitis and fatty liver disease. So obviously pancreas with changing of islet cells, both alpha and beta islet cells. And also, by the way, just got on 2 other guidelines, which are not on this picture. It got on the guidelines for chronic renal failure, as in, again, decreasing inflammation. It also looks like it may help with COPD. We haven't had a lot of things to help COPD except prostaglandin inhibitors and steroids, but it looks like GLP-1s have a significant anti-inflammatory effect on chronic lung disease. So bottom line of all this is there's going to be a lot of people on GLP-1s for many reasons. Our understanding of that and being able to help them with attendant weight loss and metabolic tune-up turns out to be, I think, very important.
Yeah, so quite the flurry of research here. It really is just mind-boggling. There's a lot of activity. So on our next slide, bringing it back just thinking about weight loss and how we ended up here. Weight loss is what's really gotten these on the map. But what this slide is showing is that these medications have been around since 2005. The first GLP-1 medication came out in 2005. The green ones on this list are diabetes medications, originally released for that blood sugar control and insulin effects that Dr. Rothrock was talking about earlier. The blue medications are the introduction of obesity as an indication for these same medications. So each of these are different branded medications that are GLP-1s. Now, going along the x-axis, the longer the line here, it means more weight loss. So over time, you can see that the more recent blockbuster drugs that we see just coming out in 2021, Wegovy with semaglutide. That's, I think, when we all started to sort of pick up on this trend here. That's where we really started to see such great weight loss that these really became a thing. So, it's not about knowing, in this case, I think it's not about knowing all the different medications, but one trend what I notice here is that the active ingredient in these medications is right now comes down to two active ingredients that are fairly common, the semaglutide and the tirzepatide, the ones that we talked about earlier. And so really, we do see a lot of medications on the market with different names, but they are often either really come down to semaglutide or tirzepatide. The weight loss medications have shown more weight loss. I think part of that is we have a different population, right? We have people who have diabetes lose weight differently than people who don't have diabetes. So when medications are prescribed for weight loss, we're seeing these really large rates of weight loss. So I wanted to just show this slide as just kind of a landscape, and then we think about what Dr. Rothrock was saying with even more advancements coming out and triple agonists coming out. So that's just a little bit of a context, but really right now, if we go to the next slide, just kind of bringing home that the two medications that are most being prescribed right now for weight loss are the semaglutide and the tirzepatide. Would you say that's true, Dr. Rothrock? Have these two really taken over?
Yeah, no, these are absolutely taken over. Mm-hmm. There's still one thing to remember is that for type 2 diabetes, Trulicity and some of the other early exenatide, some of the other GLP-1s are still being actively prescribed for type 2 diabetes. Also, yeah, we didn't talk about this much, but the GLP-1s are metabolized by what's called DPP-4, and there are several DPP-4 inhibitors that have been used in type 2 diabetes, which will actually augment the effects of the GLP-1s. And those you probably have heard, they're Januvia, Onglyza, some of those DPP-4 inhibitors. That's actually the earliest one that we had before exenatide were DPP-4 inhibitors. So it raised GLP-1 by inhibiting its breakdown. So again, understanding these drugs is not critical, but it's still kind of important to understand that if somebody's on Trulicity and Januvia, you don't probably you want to be pretty careful adding semaglutide to that because you've already got two mechanisms going on there that are similar. So,
so as a prescriber, you're maybe looking at what other medications people might be on.
Absolutely.
If you're just a coach and you come across, sorry, I didn't mean to say just a coach, but I mean, for the rest of us who aren't prescribing and deciding, what should we take away from if we see a medication that name a brand? Does it matter if it's Wegovy or Ozempic? Does it matter if it's Zepbound or Wegovy? How is that going to change how we're coaching?
Yeah, I think you're going to, it's very clear that the semaglutide, the Wegovy drugs have more side effects than the tirzepatide and Zepbound. So I think if the client ends up being on Wegovy, you're going to see more side effects. Tirzepatide, much less and possibly more weight loss effectiveness. Tirzepatide and semaglutide were actually studied against each other. The only two of these drugs that have ever been studied together. And in that nose-to-nose study, tirzepatide was superior, both in side effects and in weight loss. So, given cost constraints and insurance constraints and all these kinds of things, tirzepatide is probably the winner in this group of medications. Although Wegovy semaglutide was the original, and at this point, the only oral drug that's available is semaglutide. That only became available about 4 weeks ago. I have 10 patients on it, I think, right now, and it's pretty effective. But I had a patient today, just actually 15 minutes before this talk, who got put on the lowest dose oral Wegovy, and she couldn't tolerate it. It was too much nausea, so we had to stop it. So, all of these things are in our clinical experience are evolving, and again, with the oral Wegovy being only available for a month, we're evolving our own experience with it for sure. So, but I can tell you that injectable and oral are going to be quite different, I think.
In what way would you say?
Well, I think it's going to be convenience mostly.
Mhm.
If a person can tolerate and get adequate weight loss with the oral Wegovy, I think an oral preparation is going to be ultimately more user friendly, if you will, than injectables.
Yeah, absolutely. Now, people are getting medications from all kinds of places. There's a lot of names out there, a lot of advertisements for other brands. How do those relate to semaglutide, tirzepatide?
It's a really difficult question. It's overwhelming how many sites and in our little town, you know, everybody that seems to have any kind of shingle, including massage therapists, are trying to provide weight loss medications. I think that's not a great trend. I think that the side effects of these medicines and the ability to coach like we can and provide nutritional information is of critical importance. The other thing that's important is the compounded compounds. So, just a 2-minute story on all this. When this all broke 2 years ago or so, semaglutide was the original, and as Ozempic, and the company, which is Novo Nordisk, could not provide adequate amounts of drug compared to the demand. The demand went through the roof, as you all know. I'm sure you've all seen it. The result of that was the FDA allowed compounding pharmacies to produce similar drugs. They weren't all identical. Some had 30 amino acids, some had 31, so they weren't exactly identical, but they were peptides that were similar. And that's a great deal of was being marketed for the last couple of years. They were never tested in a clinical trial. They were basically utilizing the data from the previous trials from semaglutide, and they're not necessarily identical. And then what happened was both Lilly and Novo Nordisk kind of caught up and said to the FDA, "Hey, well, now wait a minute. We can now provide all the drug that meets the demand." And so they attempted to shut down the compounded preparations, and that has been mostly successful. There's a big lawsuit that's against that Lilly's suing people and Novo Nordisk is suing people, trying to shut down it. And what happened was the compounding people kind of did some stuff to try to get around the ban on, which was back a year ago, almost May 22nd is when the ban was by the FDA, and they tried to get around it by adding B12 and vitamin C and some other stuff to try to make it not look exactly like semaglutide. Obviously, that's not a perfect solution, and as to their availability and their efficacy and their safety, I think there's always a question of that, because they really have not been studied.
Okay, so even the compounded medications they're trying to look like semaglutide, tirzepatide at this point. but maybe that'll change. We'll see.
Yeah, again, that this whole area is changing. It's so fluid and changing all of the time that it's hard to frankly keep track of it. Um, the other thing too is I think that the actual pharmaceutical companies are trying to make the cost of these things more competitive as well. So they're kind of in the marketplace working with it too. When Ozempic first came out, it was more than $1,000 a month. And now you can get it for $249 a month. And actually, the pill, to start off on the pill, it's $149 a month. So again, the cost structure is changing as well.
A lot of
Um,
change coming down. That probably will put more people on these meds.
right.
Let's bring it back to the patients who are in front of us and go to the next slide. Because I know people have questions about dosing schedules, and when people start these medications, they can come to us at various points. What is it like when a person decides to start a GLP-1 medication? Walk us through what happens.
Well, I think the most important thing is to be aware of the side effects and the fact that they can occur even at the lowest dose level. I'm not sure, since I've never spoken to anybody at Novo Nordisk in Denmark, but I'm not sure why they ended up uh, creating these dose schedules, and so.
It's a
But
process to get on one of these. I'm seeing like 30 days. That's 4 months.
right,
5 months, 5 months to get up to the supposed maintenance dose.
exactly. And it takes a while, and it can be frustrating for people because again, they're being put on this drug that costs a fair amount of money, and they really kind of anticipated fairly quick results. Don't always get quick results because you don't get the significant weight loss effect necessarily at the starting dose.
And why
Some
is it that we have all these dosages,
I
all
think
these differences?
to compensate for the side effects and to let a person compensate to the medication. And by the way, just last week, the maximum dose of injectable semaglutide was 2.4 milligrams. FDA just approved a dosing schedule of 7.2 milligrams for semaglutide last week. So, again, where that, for that's mostly for weight loss. So where the weight loss part of this and the diabetic part of it and where the dosing exactly happens, it'll be some years, I think, before we totally understand that. But the fact that Novo Nordisk more than doubled the diabetic dose for weight loss suggests that there's some higher dose levels that you can go to get more effective weight loss. And again, that just happened last week.
And do you see clients or patients who come in and they don't need to go all the way up to the maintenance dose? Is there variability between person to person, whether they follow the schedule or how they feel?
Absolutely. And once again, one of the areas that we've looked at in Ideal Protein with our synergistic programs is that we try to keep people at lower doses, try to keep people at the lowest dose actually, or next to lowest dose, and add on Ideal Protein as our synergistic thing and not blindly increase the dose up to higher dose levels because we feel that you get augmentation of both the GLP-1 and the ketogenic phase one put together, and you don't need to titrate the dose. So we're considering or thinking that we don't need to blindly titrate dosing. Um, the clearly, like all drugs, the higher you go with the dosing, the higher your risk of side effects are. Now, I mean that so if you can get the positive effect that you're looking for by a lower dose of the medication, um, that's always a win-win. It's always a win-win. And I have seen people on the initial dose of Ozempic at 0.25 milligrams have unacceptable side effects.
Mhm.
So this dosing increase really is something that's important. There's in fact today I had somebody you have two things today. This is all stuff that's happening right as we speak almost. But today, I had a person that was not tolerating Ozempic and we had to switch, wanted to switch, she wanted to switch to tirzepatide because it does have less side effects. And the problem is, well, what do we do with that? If because they were on a moderate dose of Ozempic, and what we decided to do is go all the way back to the beginning dose of tirzepatide and re-titrate them. So, a lot of this stuff is so hot off the press. We're kind of working with it in the clinic to figure out what's the best way to do these things. So, very interesting things.
Yeah, I appreciate that, and bringing it back to our coaches, I think it's a good reminder that what we're here for as coaches is just to be that structure to keep people consistent, and knowing that there's this flexibility, this a little bit of unpredictability. I think it's helpful as a coach to know that it may be a bit of a bumpy ride, and that's to be expected. But on the other end of the medication is a prescriber who is able to look more deeply and think about that medical level as well. I want to bring in our questions. We haven't had too many questions posted. If you have a question, please let us know. But Ingrid had a question about kind of more the later phase of the journey. So when a client gets to their goal weight, either to how to support the clients, whether we wean off or do we continue at a maintenance dose? Does it get treated like phase 2? And Ingrid, if I botch the questions, please feel free to come on and clarify.
Well, I think actually that's probably one of the most important questions in this whole field, and there is no answer to it at this point. First of all, one big study that was done on people that were discontinued totally from Ozempic, over a period of 6 months, gained 75% of the weight they lost. So whatever the GLP-1s are doing, they're not doing anything that's long lasting. When you remove the GLP-1, you're removing the effect. Now that's an area where I think us and Ideal Protein can be potentially really, really beneficial, because as we train people and coach people and give appropriate nutrition and we work into phase 3, that may be a way to maintain weight and maintain metabolic health without continuing the GLP-1s. I don't know the answer to that. There's been no good study published on what to do with GLP-1s once the weight goal is obtained. Again, not talking about phase 3 at the moment, but just people that were on GLP-1s and lost the weight. Uh, uh, some people extol just continuing it and treating it somewhat like a blood pressure medicine, that being overweight is a disease, and that is being more and more accepted, that it's a disease, not just a lack of willpower or whatever. And just like high blood pressure, I mean, if you put somebody on a high blood pressure medicine and their blood pressure comes down, great. But if you take them off the blood pressure medicine, guess what? Their blood pressure goes back up again, because it is a disease. Same, I think, with obesity. So I think in the long run, there's going to be some long-term use of GLP-1s, and they aren't going to come off of it. Now, there's multiple ways to look at how to keep people in a maintenance dose of GLP-1s. There's increasing the frequency, doing it every 2 weeks instead of every week, doing it half dose or reducing the dose again, back down to starting doses, and do that once a week. That's kind of a micro dosing thing. There's micro dosing that's being looked at. So there's a lot of different things being looked at, and I don't have any real clear guidance in my own clinic with people that have reached their goals, because and interestingly enough, if you look at insurance, of course, insurance is kind of crazy about this. If you get people down to a normal weight, well, now they don't qualify for the drug. And that actually happened last week. That the insurance company, which had previously supported GLP-1s, now is not, because the client's at their appropriate weight. So
Wow. Evolving.
Evolving.
So we have a question from Joanna. I think we've got time for this one other question. And Joanna is asking, what happens when a patient is put on a GLP-1 for another condition and does not need to lose weight? Would the low carb flex be an ideal option?
Absolutely. Low carb flex, and we've got some other things in the pipeline maybe out there to think about as well. But again, that there's not a lot written in the literature about this yet, even in the cardiology literature, when people are being using it for congestive heart failure. I mean, one of the problems in congestive heart failure, little clinical pearl for you folks out there, is that it reduces your appetite. And people go into what's called cardiac cachexia, which means they lose weight in bad heart failure. So if you added a GLP-1 to that, is that going to make that worse? Those are kind of evolving questions as well, and making sure that patients, elderly patients, have adequate nutrition, specifically protein, is key. And in my life with Ideal Protein, it's changed the way I practice cardiology in the sense that I want to make sure that everybody um, is getting adequate protein. And I can tell you, 99% of physicians never talk to patients about this. Um, that they just put people on the medications and uh, don't work with the basics. And the basics always is always nutrition.
Mm.
Always nutrition.
That really, really reinforces the need for our services.
Absolutely. And our great coaches. I mean, this is what we do.
All right, so this was really quick, Dr. Otherag. We really thank you for coming on and sharing these great insights. Our next SAB Talks will actually be at Super Weekend. Can you give us a quick hint at what you'll be talking about at Super Weekend?
Well, we're going to talk about some new thoughts about why people have a hard time in maintenance. Some of the new thoughts philosophically about where we're going in our thoughts with maintenance in phase 3. Some theory behind what's called glycation is going to be one of my big topics I'll be talking about. We'll also, of course, we'll do some more GLP-1 talks, and any news data that's come out, of course, we'll try to present it at that time. We'll have formats to have questions, obviously. Some presentations about some of the things that we're working on to be adjunctive to GLP-1s, I think are going to be one of the more exciting areas that we're going to be talking about in Super Weekend here. So a lot of hot topics and hot news coming on with the Super Weekends. Hope to see all of you there.
Hope to see all of you there. It's not too late if you haven't registered. If you can get to Super Weekend, the whole science advisory board will be there. Dr. Tran will be there. There's going to be a photo booth. Our marketing geniuses will be there. Our amazing account managers and more. So it'll be a great opportunity to continue to connect and ask more questions. And that's it for today. So thank you all so much for dialing in. One last thing I want to mention is we are also coming out with some more resources on GLP-1s. There will be a new interactive GLP-1 training landing soon in the IP Academy. So be on the lookout for that coming up in the weeks to come. And otherwise, we'll see you at Super Weekend. So thanks so much for joining. Bye, everyone.
Bye-bye. Are we off the air?
Almost. Okay, we are off. Thank you. That was great. It goes so fast.
It does. It does.
Yeah. But I think people liked it. Not too many questions, but that's all right. We kind of gave us more time to go off into details, and you brought a lot to it. So thank you so much.
Okay. All right. Thanks, everybody. Talk to you soon.
Okay. Bye.
Bye.